Keith Feldman, associate professor at the Department of Learning Health Sciences at the University of Michigan. He is a computer scientist by training and has focused his academic career on exploring how machine learning and data science techniques can most effectively address challenges across healthcare. A core theme of his work has been augmentation, not automation. Rather than applying computational models to replicate clinical decision-making, his work explores how data-driven approaches can enhance it by identifying what information, if made available, could improve decisions and workflows. His work has been supported by the NIH, AHA, Frontier CTSI, and generous Feldman gifts. Welcome, Dr. Feldman.
Thank you. So I thought a lot about kind of what I was going to talk about. So I recently moved to Michigan, so I'm still learning. So it's nice to meet everybody. I thought a little bit of kind of about what CHEAR was and going through your website and kind of thinking about like what really kind of where we're going to be moving going forward. And to me, it's a little bit of this balance of like, what does it mean to be a computer scientist, like working in a computational space in healthcare, right? We think about, we are notoriously bad discipline in building things that nobody cares about, right? So we've built things for years that just don't work and don't translate. So really, I've been thinking a lot about like, how do you build models and that reflect the complexity that comes from CHEAR. So we'll talk a little bit about that. I meant for this to be a little bit less formal. So I did watch your seminar last week. I heard everybody asking questions. I expect the same. People should stop me. I'm an engineer. I'm super comfortable with silence, but I ask questions and stop. So I think the best place to start is that like healthcare data is complicated, right? We know that there's a variety of issues from it. It's heterogeneous, it's sparse, it's correlated. There's a ton of problems that comes from a lot of different places. But I think what we forget is that it's complicated because healthcare is complicated. It's multidisciplinary. There's a lot of places and there's a lot of longitudinal aspects about this. And where I think this leads us into some issues is that it creates issues across what we think of as a analytical pipeline, right? The collection of data, the formulation, the structuring of it, the modeling it to get to some type of insight. And where I kind of want to spend today thinking about is the first two sections. I think that we often focus a lot on like, how do we get good insights? But I think we overlook that the decision of what we structure and what we model and how we model it have a strong impact on that. And I think both of these are places that we can spend a little bit of time doing better. So I'm going to do something a little bit different. So we're going to be talking about all ongoing work. So please, if you have questions or thoughts, I'd love to hear them. So I think the first place is that data alone is not enough. I love this picture. It's a good computer science example about that we just build things that don't work, right? So I think if anyone's worried about AI replacing them, it's not going to. But I think data, we think of data as, the core of, the new goal. We've heard it a million times that data is really important. I would say that data is not really what we're looking for. What we really mean by this is that context is what we're looking at. And when we think about healthcare, what we actually mean is that it's a variety of things, right? We're not picking clinical attributes. We're not thinking about a variety of, demographics or sociodemographics. We're really thinking about a spectrum of information from the individual all the way to the population policy levels in the areas in which they live. Making it more complicated is that these attributes evolve over time. So individuals are not static, neither are the communities in which they live. And the data we collect from them reflect a point in time, not necessarily an individual. It's a cross-sectional slice. And I think developing and thinking about how do we model and appropriately process this information that accounts for the reality of what this is important. So inevitably, somebody will stop me here and they'll say like, we'll just get more data. Like this will be easy. And I think that's true. And I think it's really valuable that like we could do better. We have amazing pipelines to collect data. We have amazing ways to collect huge volumes of information about any individual at any point in time. I will again tell you that information is not going to be sufficient. Again, computer science, AI will never replace you. But I think it's really important to think about the idea that information, despite how good we are at getting it, is not really what we're looking for. So I'm going to argue about this idea of context. So it's funny to show images. The reality is that we know that this idea of context reflects in real world data all the time. Figure on the left is a really famous example in which all of these have the same association between the two variables. They're fundamentally different distributions. Figure on the right is really the famous Simpsons paradox, where we have 5 cohorts with a positive association, but overall they look negative. And I think these really are just contrived examples, but they get at the core that it's not the collection of information, it's the understanding about the data generation process that really informs kind of what we build modeling and how we translate this into care. So I like to argue that form drives function. So the way that we structure and we process this data really drives how we will use it. So broadly thinking about how my group is going to think about this, we kind of have 2 arms, a methods arm, thinking about how do we build methods that better reflect the complexity of real world data, and also like how do we translate this and use it in the clinical settings. So I did move to a Department of Learning Health Sciences. I think I'm legally obligated once this should talk to have this cycle up here, but I think generally the idea that the way that we process this information and we think about form and structure, I actually do think fits really well into the LHS. I like to give people a little bit of like background into me. I used the learning health cycle in part of my dissertation like 15 years ago, not this pretty picture, but a much more contrived version. But I do think that there's really several areas that data informs the learning cycle. And today I'll kind of want to talk about three areas. One, a modeling aspect, how do we build models that actually reflect complexity of care? How do we contextualize data during decision making, and really like how do we improve what we consider the use and processing of data? It's going to be a little bit backwards. So I want to start with one that maybe spans both translation and methods development. I originally had this actually at the end of the talk. And again, I saw you guys stopping the talk last week. And so I want to start with this and then we can break it down to specific things in case we don't get to the end, which would be great. So the first question I think is, we have a lot of data, and I would argue that we tend to use a small or fairly utilize a large chunk of what we have. And I would argue like why? Well, it's because we need to structure it in some way so we can model it, right? I mean, the truth of the example is that people have a lot of data, but if we want to do something with it, we need structure. I don't think that we've done a very good job about that. If I ask you to build me a descriptive vector about an individual, right? You can pick things that look very similar. It doesn't mean that these people are very similar. And I think if you take nothing away from this talk, is that the individual features that we use to represent a person or an entity or an organization, like they tend to be a subset of a larger, broader information. And we often overlook this because we need to model it. We need structure. And I think that that push and pull between the two has created a lot of issues. So we've been thinking for the last couple of years about like, what does it mean to select information about a person to model them? I think the best case example that I wanted to use for today is case control studies. I think it's in that this group would be familiar with, but matched case control studies are a really great place for this. We know that cohorts are fundamentally unbalanced from observational studies retrospectively. We've done decades of epidemiological research around matching these individuals. So I think it's a perfect example to think about selection or underutilization of data. So if I asked you to do a case control study or matched case control study, people tend to start with something, right? They tend to start with attributes that we want to match on something. So we'll get age, we'll sex, maybe we're really progressive and we'll get disease state and comorbidity, and we'll do a really good job characterizing a person. And we will find, all these things that we know about them. And we do an excellent job. We put these pretty pictures in our papers and everyone loves them. They say, like, look, we balanced this so well. These cohorts are great. Well, again, we know that this is only a small part of that person, and we know that's only a small part of their care process. So what does this kind of contradiction imply? So the first question is like, what happens if you just pick something or miss something? There's some, go away, thank you. What if we miss a variable that's really important? We miss a confounding factor, we miss something important. Well, we asked that, so you can simulate that. So you can build a propensity score, you can build a known case control study and just start missing things. So if you have all the variables and you model them all correctly, yeah, there's really low bias. You can estimate it really reliably. The more things you miss, the worse you get. I don't think this is a big shock. I don't think this really drives home anything, but I do think it's important to realize that you are essentially saying that we have picked the things that we know work. And I think that's a bold statement to make as a researcher, that we know everything that's going to impact this outcome. We can do our best, but it's usually not quite enough. The contrary to this is that people will say, we'll just do everything. Well, that's not possible. So we tested that. So we took a medical record, a couple hundred kids, 144 kids out of the NICU. I do a lot of neonatal research, so bear with me as I talk about a lot of our babies. But we just started grabbing hundreds of variables from their medical record. We just said, how many kids have these 10, these 20, these 30? By the time you get to 25 or 30, most kids don't have everything measured, and they don't need to. Some of these kids don't have anesthesia times. They didn't have surgery. That's great. Some of these kids don't have lab tests. Well, they didn't get it done. They were discharged in a few days. Missing this is not a detriment. It's that this is just a product of their care, and we don't necessarily consider that. So we've been thinking about reframing this question. Instead of saying, can we pick the things that we know about a person? We're really interested, can you build representations of the individual as a whole? So there's a field of, we're not going to spend a ton of time on the technical details, but I'm happy to talk until you are bored and leave me about any of this later. But I think the idea is that representation learning is a large field in computer science. How do you build structured representations of an individual set of data? And they've been useful in fields like mechanical engineer or mechanical aviation. They've been great in manufacturing, and they tend to be really structured and they have a lot of complete data. So they've been the fields leading the way. Healthcare's had a lot of missingness and it's created some issues around these representations. This is starting to move past this. We have great masked representations and the ability to handle uncertainty. So we've been thinking about what do you do? Can you build this vector that represents a person? For people that are maybe a little bit less familiar with like embeddings or representations, you can think of it like a semantic representation. It really starts early in words, bathtub and bathroom really have no structural relation, but they are semantically similar. We're looking for a very similar thing for individuals where they don't have to have exactly the same attributes, but interchangeably they have similar things done to them. And what does that get you? It's a lot of math for not a lot of benefit, but it gets you the ability to compute numbers, and the ability to compute a number between or distance between two people is really valuable. What we tend to over describe in what we do is that really what we're trying to understand is similarity between people, and similarity between people is a lot easier when they are represented as vectors. Now, does that mean that this is perfect? Absolutely not, but it does mean that it gives us a path to get a bit more complete understanding of an individual. So we've thought a lot about, kind of where our contribution in the space is case control studies have been basically set up in the same way for decades, where you pick a bunch of factors that you don't want to study, you match on them, and then you study something else. We're trying to ask if you flip this. So tell me the things that you'd like to study, and we'll match on everything else, right? You can't match on everything. You overmatch, you get lots of bias, there's lots of problems. So can you flip that paradigm into thinking about, if you tell me what the outcome that you're interested in or what the exposure you're interested in, let us build representations of the rest of that patient, things that are non-correlated. There's a whole bunch of things that go into this so you don't introduce bias. But really, can we better understand who we are building on to get better estimate cases and controls that represent the whole person? So our current work in this area is on spontaneous-associated liver disease. It's a great example because patients don't just develop this until they're older. We're really interested in how insults in the NICU impact this. So a lot of things are done, hepatic injury in the NICU is quite common, and these kids develop liver injury later on. So we're really interested in, are there impacts to your development of rate of spontaneous-associated liver disease if you have worse liver in the NICU? Well, what's great is, so I guess this is a little bit less late breaking now. I thought it would be funny to call it that, but I guess it's a couple of months old, but you were one of the first people to see it. So we'll call it late breaking. The idea is that so we did some work looking at, do patients with liver injury develop spontaneous-associated liver disease faster? And they do. Overwhelmingly, our method finds that this is really good, that this hypothesis worked out. I can be very happy about that. That's not really why I want you to see this. What I want people here to be excited about is that we did this with our method. It's great. Then we went back and hand matched these kids with how an epidemiologist would do this. And we got very similar scenarios with hand matched, expertly chosen variables. We didn't have to pick the things to match on. We didn't have to pick the things that we were looking at. We didn't have to find confounders. We're really interested in, can you generate similar estimates? So scenario 1 and scenario 2 are both expertly matched scenarios based on things like gestational age, birth weight, liver injury, platelet counts. And then scenario 3 is a negative control where we randomly pad kids between the two of them. And you see that it's not just a fluke, that the kids are fundamentally different. So this is quite exciting, both because it's clinically very interesting and I'm excited for our path forward, but also I think this really lends some credence to this idea that we don't have to be spending all this time thinking about everything about a patient. We can start to think about the patient as an entity and then do cool things with that entity rather than saying this person is a characteristic of 6 things. What does that mean now? Like, I still think that we're not all the way there. So we're trying currently to extend this into trajectories. So these cross-sectional case control studies have been great. I don't think that they really capture what we think that they capture. They capture what 2 people have as a cross-sectional set of attributes. They don't really capture these patients' pathway through our health system. So we're actually looking at extending these representations to a trajectory, saying that can we match on 2 individuals that have similar trajectories through health care processes and experiences, and then how that impacts their outcome. And I think this is going to be where we can really use these representations in a novel way. The embeddings are great for the cross-sectional work, but I don't think that people would argue that we need them. I think they're great because they remove some bias, but we've had good studies for years. I don't think that we should argue that the other ones are bad. This is really a novel approach, though. We don't have ways to do cross-sectional or repeated measure case control matching without having time points till we match on over time. We also have, this gives us a little bit of flexibility to think more broadly about what are we actually studying. So when I ask you to case control match individuals, we study individuals, so similarity, based on things that we know. We don't say this out loud, but we're only assessing the things that we already know about a person. That's inherently limiting, right? The things that we don't know about a person are also quite interesting, the things that they didn't have done to them. And this ability to capture uncertainty is really exciting. So we have another line of work in collaboration with another university kind of spawning out of this right now, thinking about, what does it mean to not collect information and how do we capture similarity in a more probabilistic way? So in particular, imaging has done this for a really long time. So fuzziness, so I think that they make great pictures, so I'm happy to steal with accreditation some of their pictures. But the idea that we don't always know what pictures are. So the figure on the top shows a blurred blank and then a 7. Well, it could be a 17 or it could be a 14. So like, why pick? They've done some really cool work with this idea that you can generate a probability distribution, that it could be a 17 or it could be a 14. Same thing if we think about blurry or fuzzy images. Well, there's lots of ways that that image could generate. Well, we're interested in thinking about it. Can you do that for individuals? And it turns out that you can. So what we don't know about an individual actually doesn't mean that it wasn't there. So if I think about the similarity between me and Cal, if we have 5 things measured and 4 of them are known, well, our similarity actually depends quite a bit on that 5th, if it was realistic, right? We could be very similar if the 5th is matched, or we could be very different if that unknown variable is there. Like, why ignore that uncertainty? We can estimate what that, instead of treating a person as a point, we can treat them as a space based on what we know and what we don't know. And from that probability space, you can actually do some really cool things, looking at how similar individuals could be and how confident we are that these 2 people actually are good matches based on what we know and what we don't know. We can add to this, which I'm not going to go into a ton of depth, but also thinking about structural missingness. The things that you had done to you are informative. So the pattern of testing and the pattern of non-testing, the actual the ones and zeros of what was done, what wasn't done, that pattern itself can actually be included in this. We've got some work looking at, does the structure of the missingness, the structure of what's known, impact similarity? And it does quite a bit. If everybody who had these same 15 variables measured is similar in some way because they all went down the same CHEAR pathway, and we get a lot of really interesting work out of this. So from moving individuals from a point to a space, I think there's been some cool and exciting work in this area.
Can I interrupt and ask
Oh,
you a
yes,
question?
this is the best. Please.
So just trying to wrestle with this concept of trajectories
Yeah,
and missing data, right?
yeah,
So in an ideal world, everybody's getting the best, most complete care, right?
Yeah.
That doesn't always happen, and there's a lot of reasons why that could happen. But understanding which gaps matter and which gaps don't matter.
yeah.
Like, can you
Okay, so.
wrestle with that?
Yeah, so okay, we'll get to the gap. So actually, the next one here is gonna talk about gaps. So you're 1 slide early, but I think the 2 things. So the what's there and what's not there, we're thinking more at a cross-sectional state, not the trajectories. Because the trajectories you're dealing with timing, not just missingness, right? Because we're trying to think about 2 people that had similar trajectories. So this cross-sectional one is really thinking about this uncertainty space is thinking about cross-sectionally. So when we take a snapshot of a person, we don't have that information. Can you generate that probability space of there? The trajectory question is thinking about more, does the sequence in which you received or the pattern in which your own data changed, can we generate that sequence quite well? So I think the best analogy would be like finance has done this for a really long time. They built these trajectory embeddings off of stock prices where you have a single time series over time, and they're finding 2 similar performing stocks where you have a single variable. People have done this now with EKGs, with weeds, and that's done really well. We're asking, can you extend this into a sequence of clinical care? So the gaps are less important there as what your path of what you are measured is. So think about 15 lab values. I want to model that trajectory of that lab shape and see if individuals that underwent similar trajectories of that lab shape, not the care, missingness, and the gaps. The gaps are actually from another project in 2 seconds, but the gaps themselves are informative for different things. So the gaps for cross-sectionally are informative for what wasn't done at that time. So can we actually process? So like this is a perfect example. So person 1, we went to the eye doctor, they had their blood test, but they didn't have a PFT, right? So they didn't measure their lung function. Like, does that mean that their lung function is 0? Like, no, it means that they didn't have it done. Does that mean that we should impute it? So like, I'm a strong advocate to not impute things because I think it's challenging and adds bias. But it doesn't mean that that value is meaningless. It means that we know where they could have been, and we can use that structure of that pattern of care to actually incorporated into that. So think of them as parallel, not overlapping. So the pattern and trajectory of what's known is great, and the structure and what we're doing is also great. We're looking at, can you fuse those two together? They are parallel but not overlapping. Does that make sense? A little bit? Okay.
I'm getting there.
Okay, yeah.
Related, and maybe you're gonna cover this also, but what I was wondering about the missingness is things can be missing for different reasons.
Yeah.
Something wasn't done because someone was well and didn't need the test, or because they were unable to get to their care or they couldn't afford it.
Yeah, so I'm not gonna do it in this talk because I thought it was gonna get too down to the weeds, but I think, yeah, you're right. So this, the pattern, like missing not at random, like the patterns of missingness are really informative. So we are testing that. And then the idea that the parallel trajectory, so both of those are embedded in their own. So the structure and pattern of missingness gets its own embedding, and that is fused loosely with the actual known data. And what we find is that you can actually recover missing completely at random and missing at random quite well. Missing completely or missing not at random where there's latent variables is still going to be challenging. But if it is a recognizable pattern from CHEAR or who they've seen or encounter patterns, like if it is a observable pattern of missingness, we can model that quite well. So we've gotten 2/3 of the way there. So you can get completely random missingness and at random observable structural embeddings. That works quite well. It's just the latent one is still challenging, which I think is always going to be challenging. But those two work quite well. That's a great question. So maybe I should have had more technical. This is great. This is good. Yeah, please.
I'm an epidemiologist, so all I think about is, are you measuring things correctly or not, essentially? And, when I think about your inputs and the things that can drive your inputs.
Yeah.
And the things that can influence if data is incorrect or correct differentially.
Yeah.
How do you think about that when you're using these fancy methods, if the actual baseline data is, yeah.
Yeah, so I would say.
Bad for different reasons with different people.
Oh, good point. Okay, so I will totally honest, we don't think about it for this. This is just trying to represent individuals. We do have a project actually looking at temperature, assessment of like temperature, body temperature. And we are looking at how do you account for the potential error that comes from thermometers and for measurement, and looking at methods that account for like in a permutation based. So like for measurement error, so let's talk about technical error first. You can account for that. You can account for that in computational ways. For lack of access for patterns, we're hoping that the structure and pattern of what's available is useful. So like you're not measuring something, but are you asking like if you did measure it, so they got care, but it was still poorly measured? Or are you asking they didn't get it because of some latent factor where they just don't have access to that machine?
Both, or they just do not show up to receive care at all.
Yeah, okay, so they don't have this because they didn't come is something that we think we can account for with the structure. The measurement itself is missing, right? And I think that's why we want this. This extension came from that question, is that when you look at existing methods, like existing embedding methods, or really any embedding method, you are measuring essentially what is captured, right? That's anything. In case control studies, I mean, any of these approaches, you are just measuring things that you know. I think this actually came, so the extension to the spaces actually did come from your question, where they didn't come to care, but it doesn't mean that that variable is not important. So the structure of their missingness itself has been useful for similarity to other people like them. So it gives us the ability to better estimate similarity between people. Now, do I think that that's perfect? Like, no. But do I think that it's better than what we can do by ignoring the fact that they didn't have it measured? Yes. Rather than imputing it. I would, but I'd love to hear, I mean, if there's things that you guys are thinking about specifically, there's ways to integrate additional information at any stage. So we are open to adding or moving. But I think the question of like, if you didn't come, like, why didn't you come? I don't think we'll answer that. But I do think that you didn't come, we can account for that missingness because you missed your appointment. We can do that. So you're moving, you're not there. I think it's moving in the direction. Do I think that there's better? 100%. If you have thoughts, I'd love to hear them. Like, yeah, we can talk later, we can talk now. So,
Oh, I
Yeah.
cannot talk about this now.
okay.
There's-
So,
Let me just
yeah.
make that point clear.
Okay, yeah. But I think we should talk about that, because I think it is important. I think, yeah. Did you have another?
To what extent might there be a third reason, which is you consistently do this test in this situation and you
Don't.
don't?
Yeah.
And it's not a random thing.
Yeah, so. Yeah, this is we're getting maybe into some of the nuance of like, I try not to talk about like provider variability very much, but like, I mean, it's reality that it exists. So like when we think about care in the NICU, we think about unit level variability, especially between like what's available. So like sites that don't have ECMO aren't giving ECMO, like that's just what it is. So like, I think that the availability of information, the easiest way to think about this is that I'm trying to move away in general from this idea that we are assessing people as measurements, discrete measurements. If you think about embedding space, it's actually jointly learned. So you don't have that information because it wasn't done. Doesn't mean that in this space that you still can't be similar to people that don't have it, right? Just because you don't have it measured, it doesn't mean that you can't be similar. The embedding space in which you're learning this is just a probability space of like things that you measure about a person. So it would be less likely that you're similar, but it doesn't mean that you can't be similar. You can't measure similarity between them. You absolutely can. And that's actually the whole fundamental idea here is that if you don't have ECMO and you're measuring, comparing to someone who did have ECMO, there is no math today that can do that. There's no similarity measure between someone that got something and someone that didn't. We're hoping that if you move people into any space, then you can compute a similarity between them. Maybe it's not the best similarity, but it's now possible. So like the idea is that if I didn't go to a clinic that didn't test at all, there is no way in which I use those features and I get a measurement of similarity to somebody who got that test. There's just no number there. But if these two people exist in the same space, there is a number. Maybe it's not perfectly similar, but they are at least computable now. So it gets you that closer there. Yeah.
I'm trying to wrap my head around utility of what you're doing in the clinical space. And whether or not what you're, and I'm asking now,
Yep.
I'm testing an inference, whether or not what you're trying to do through these methods is a different mechanism or method of defining the variability or uncertainty that exists between different, let's say within a population or across individuals.
Yeah.
To be able to, and I can only think of it in terms of your case control example,
Sure.
But is that what this is all about?
No, this is ideas. We would like better estimates of patient similarity. The core of this is that we cannot measure similarity between individuals well. We think that we do and we don't. We measure similarity based on a small set of information that characterizes a person.
Agreed.
All of this work, all of these works are our idea that we should be measuring similarity across the person, not a set of information. So think of like a bedside monitor. So like we have some work thinking about dynamic lung compliance in neonates. That's great. There's a ton of other measures that come off the vent. Like, why are we just focused on this one measure? Can we create like ventilatory profiles of a kid? We want to get two kids that have similar ventilation profiles. So I'll talk about this at the end a little bit, but like there's 1,000 levers to pull to get to the same place. We can increase their PIC, we can change their maps. Like there's so many things that you can pull to get to the same place that like traditional feature-based work is problematic because you can't measure associations of a feature because that feature is a product of care. So some places run high PIC, CHOP, some places run high PEEP. So there's all these different decisions about how you manage a kid that are site specific, that are products. Like why characterize, so like we do this all the time, right? The association of this variable to this outcome, or this cluster, this profile to this outcome. But like why? So the whole core of this work is, can you measure individuals more comprehensively? So can we say these two kids had similar ventilatory profiles? They had different management styles, the way that they got there, but they had very similar profiles in their vents. Their sequences look similar, they have very similar IO outcomes. And we're looking for similarity across a more, think of it just as multifactorial similarity. Yeah.
But ultimately, you're trying to figure out a better way to see if people are similar or not.
Yeah.
And at the end of the day, from a utility standpoint, you may find some things that are more similar through your modeling and other things that are less similar through your modeling.
Sure.
I'm hypothesizing. But at the end of the day, there's a reason why you're trying to do that.
Yeah, okay, so.
And when you get to the end point, it's because either A, you're trying to be a better predictive modeler than what we already have for treatment decisions. I'm hypothesizing.
No, you're totally right. So this gets at some, I don't like talking about myself or my lab, but like this is really like the core of our work. So our core of our work is this idea of augmentation and automation. So the core of the work is thinking about how do we augment processes or decisions that are already going to happen rather than replicating them. So none of this work is meant to predict an outcome. It's meant to inform decisions, to decide when we are making a decision, how do we do something better? So thinking about like extubation for a kid, like I do not want to predict that this kid's going to fail. Someone is already going to make that decision in clinic with the team. we are gonna think about when we are deciding about pulling the tube on this kid, what information will make our decision more helpful? Thinking about what their expected change is gonna be, what is their trajectory going to look like, and making it part of the care process. So what we think about, like computing at the core and all modeling is really similarity based, like the whole discipline. We can call it whatever we want, but like we're just measuring similarity between individuals. And by being able to do that better, we can do things more effectively. We can look at risk stratifying patients more effectively. We can look at subgrouping them. And all of that is just to inform decision-making down the line, part of decision processing, rather than replicating decisions. None of this is meant to predict an outcome.
I guess you're talking about two things to me that I am separating in my mind. And one is about kind of projecting a path forward or a trajectory of a person, and another is about kind of anticipating if they're similar to another person. And like for the missingness there, you know, as opposed to imputing, just kind of looking at profiles of missingness and postulating that those are similar to other folks who have similar profiles of missingness, that makes sense to me. And if you have their outcome, that makes sense to me. I think Sarah's notion actually is really, really important, that if, especially in kind of your example about treatment, if some of that missingness and presence is actually a relationship of treatment related decisions, actually that is maybe meaningfully undermining of this hypothesis. But I think that when you talk about thinking about this in terms of trajectories, there the missingness starts to become less clear as to how that frame of reference helps to anticipate future states.
Okay, so that's a good point. If you don't mind, let me give you 2 slides and then I'll come back to your question. So you'll be the first next question. I know there'll be more. So I like the questions about the trajectory of missingness. And I think what I want to get at for the trajectory is that missingness for a trajectory is very different when I say the cross-sectional missingness. Like, missingness of a trajectory is a product both that it wasn't done or it wasn't done yet. And I think that there are 2 different things there. So it wasn't done yet means that you still had it done. It was just done in a different order. And it wasn't done is assuming that you're omnipotent and you know that that information is never going to come. And I think those are very different processes, like data generating processes. And I want to get at maybe the latter for a second, where it was done out of order, which I think is what most people here are getting at, but maybe in a different way, that like we could test this, we just didn't do it yet, or like it wasn't available yet, or they're coming to a different clinic. So we've thought about that quite a bit. And I think thinking about
That's a
like,
different question.
yeah.
Sorry.
Oh, this is
That's
fine.
back on what you're
Back.
to my epic.
My favorite group to present to.
Oh, you say that's all.
And I'm like, oh, I'm done in 38 minutes.
So
Yes.
I guess next one, I'm still stuck on the epidemiology side of this. What if your input data is biased?
Yeah.
Like, you know, we talk about pulse ox, right? And how race
Yeah.
impacts how that is read and different things like that. So if you're putting biased data in, what's coming out?
Bias data.
I would also argue that even though there's biased data there, that biased data is what the clinical decisions are being made on right now anyways.
Right, and you talked, sorry, picking up on this, you were talking about technical error,
Yeah.
measurement error. But there's so much in clinical practice that's qualitative. Diagnostic categories,
Yeah.
you know, race and ethnicity is one that, you know, so we know is very fraught, but like, so. Yeah, like what you decide to do, what surgery a cardiac surgeon does depends on how you classify that congenital heart disease.
Yeah.
You know, whether in the NICU, somebody's a candidate for high flow ventilation or something else,
Totally.
depends on what their diagnostic category is, right? Like if you get the diagnosis wrong, like
So I think
you're screwed, so.
So I think the diagnosis question, like, I'm probably not suited to answer, like, that's problematic. I think we've tried very hard to model physiologic response rather than like classifications like codes. So a lot of what we're interested in is like discrete measures rather than like codes. I think codes are bad universally. I'm sorry if anybody's a claims person here, cow. But I feel like I'm gonna get kicked out now. No, but I think the codes have been really problematic for us for a variety of reasons, mostly for this. Because they have been really hard. We've gotten pushback time and time again that the codes that we use are not been good. So we've tried really hard to move to physiologic measures, and that's bought us a little bit more leeway in the research space. But I think you're right that like who classifies and who decides this kid is really different. I think your question about is there bias in the measurement is really a good different question. I think that's actually a project. So you're fusing like what we're currently working on to like a different project. So we are interested in how do you better adjust measurement for known confounding factors. So we have had disappearing grant potentially for understanding how body temperature was impacted by, so there's 26 factors that are known to affect core body temperature: time of day, menopausal status, medications, comorbidities, and we still use body temperature as an absolute threshold. And like, this is wildly problematic. Like, we shouldn't be using 100.4 for fever when we know all these things impact it. So we have an entire separate line of work looking at, can you develop more computational representation, like probabilistic spaces of what that temperature would be if they were healthy, and then using, like, that would be better to fuse back into this. It is not there yet. That is a totally new line of work. It looks like it works quite well, where if you know that there's factors that can bias measurements, you can account for those and actually treat those measurements as their own probabilities, basically probabilities, and then you can fuse those probabilities into this thing. And that looks like that will be where this ends up, is like, if all of our work does come back together, that would be awesome. But right now we're treating, for this work, measurements as measurements. For that work, we're treating measurement as bias and terrible things. And that, like, can we adjust for those? Ideally, that those probabilities will come back into, instead of fusing discrete measures like these will end up being their own individual probability spaces, and then those will fuse together. And that looks like that'll be the best case. Like, that would be the coolest thing I ever built. But I think that right now these are discrete and those are probabilities, and they're separate because nobody will buy either one.
Can I just take what you just said? There's these 200 things that are going to it, and then y'all build tons of things, or people build things that no one ever uses.
Yeah, all the time.
So I'm now gonna push on you a little and say, is that level of complexity of the 200 things that have to be found to know whatever, to know whether or not 100.4 is relevant to Cal when he sees a kid at, which clinic are you at? Right. At Brighton.
Yeah.
Whether they have a fever or not.
So, well, for that work, the hope was that, so we were able to show that for at least 20 of them, you can get them at the point of care automatically. So there are things that you can pull from medical record, you can pull from national weather. So like, you can compute this at the point of care. It looks like we're.
And I guess is the magnitude enough that it's clinically significant? Like whether it's 1.100.3, 100.5, 100.6, is the level of variability such that it precludes
So the answer is
clinical
no.
significance?
So I'm gonna tell you why. So I was gonna get to Sam, but we're not gonna get there. So it's no. No, it's not. So we actually tried that and it was a huge failure. We actually ended up finding it's more successful to estimate probability of where you would be if you were healthy and look at the deviation from your your measurement to that. And that is actually quite useful. So saying what we'd expect your variability to be if you were healthy, and then looking for what your measured value is to that, rather than saying, can we adjust your actual measurement? Because adjusting your measurement is useless. No one knows what an adjusted temperature means, and no one cares that you're a 0.2 higher.
Right.
They care that if you were healthy, you'd expect them to be 97 to 102, and you're 103. So like we're trying to pitch this not using the term reference range, but thinking about it as like an individualized like range, where if you think about where a non-pathologic range would be, that is very meaningful, different.
And well, that's the key, is whether or not it's a clinic, I mean,
It is.
in its utility,
It is.
is whether or not it's a clinically significant difference within the range of error that you're creating by having all of these variables that may or may not be accurate.
I would say, well, some pilot work from COVID shows that it's much more sensitive than using 100.4 as a threshold for outcomes.
It's
Yeah.
clinically resonant as well. Like families tell us all the time, like my
I'm
kid,
sorry, say that again?
it's clinically resonant as well. Our families tell us all the time, like my kid never gets a fever, like they're 90.
They always run low. Yeah,
Like,
exactly.
You know, they're not wrong. Sometimes
They run low, and then older adults don't have fever in the same way. So we tried to pitch this to NIA originally, and but they didn't care. But there's guidelines.
People here.
So I know. Well, my hope is that we're actually gonna move this to lumbar puncture for babies in the NICU, because we use fever as one of our diagnostic.
Yeah.
And I'd love to get rid of that, like we're doing too many LPs, and like I want to move that away. So like that's one of the areas that we're looking to expand that to. But let me get to Ryan's question about the trajectories. So let's think about like the complexity of care, right? So everyone's been very interested in sequences, so I should have led with sequences, I guess. We know that like healthcare sequences are really important, right? The pattern of care is non-trivial and non-random, right? The pattern in which you receive care is really important. I will say that for computer scientists, to get to point, like we have been interested for decades on if something's going to happen, not how you get there. And I think that this has been a huge failure of our discipline. We are really interested in if this is going to this outcome will happen, not how you get there. So I'll send you, you don't take a picture of it. But I think the problem of how has been because healthcare is, so I tell you that it's sequential, but it's not linear. So healthcare happens in a sequence. It does not happen linearly. Things happen all the time. So this kid, this hypoplastic kid, is gonna get kidney failure. Like, I don't think that broken bone, maybe it did. Someone here is gonna correct me, but there's some calcium metabolic pathway here. I'm sorry. But this broken bone probably doesn't work into my kidney failure trajectory. And this has been super problematic for our methods because it fragments these trajectories. So what we end up with is these really short, really easy to find trajectories. And no one cares. And that's why these fields kind of died off. Because everyone knows I can predict kidney failure and because methods can ignore noise, or I can build these really short trajectories, and that's great, but they're not clinically relevant. So we were interested in like, can you build trajectories that ignore noise? So there's a class of methods in our field, we're not gonna talk about these, but like conditional higher order networks, they're probability trajectories. So where you came from, dictates where you go. So if I know that you have diabetes, the probability of reaching this outcome and the next stage, next time you come is 50-50. But if I know what you got diagnosed in the last visit, it changes quite a bit. This comes from shipping. So ballast water exchange is actually where this comes from. So people are really worried about ecological invasive species. And when a ship goes to a port, it sucks up all this water and it moves to another port and it dumps it out. So like they built all these methods to look at like, based on where ships came from, can you estimate like what's gonna happen down the line? And like, I've been very interested in this for a long time and thinking about like, this is great if we can understand where people came from, but they don't work in healthcare because we don't know exactly where you came from and there's been lots of noise. We had been asking about like, so we can show in probability that like, if you have noise, it ruins it. You can't get this. Like if you have a really simple healthcare trajectory, so A to C leads to heart failure. If you add some noise, it ruins the sequence and you can't figure it out. So we've been spending some time thinking about like, how do you skip noise? And I think this has been a fun question to ask because Dr. Tobey's idea is like, we have no idea what the trajectory is. So like noise is not noise, right? We can't say this is noise, but you just say that they had care. So what we want to say is that this sequence of things has been relevant or not relevant to their pathway. And I think this kind of gets at that like, what is missing is not always that it's not there. It just could be it's not relevant. So you actually can't enumerate this. We tried. If you can't going forward, there's trillions of possible combinations. So it's just not possible to skip everything or determine what you skip. But what you can do is work backwards. So if you know where you want to end up, you can actually build pathways backwards. And thinking about this from lots of other ways. So people have done this for decades in these graphs. So if we know the outcome, we can say what sequence of events is informative to moving forward. And this has been really, really impactful. So what we were able to find is that if you know that you have an outcome, if I work backwards and I say, does getting some next diagnosis code, does it improve my ability to determine which way I'm going to end up? If it doesn't, it's noise. Knowing the answer to this question, or knowing if I got this test, or knowing the value of this measurement, if it doesn't help me better decide how I'm going to end up with a yes or a no, it's not relevant, at least for this sequence. And you can start to build this backwards and backwards. And we did this with several 100,000 type 2 diabetes patients across Indiana. And we're trying to run this now in the NICU, but we're still moving data, so bear with me. But we are looking at, not very long, 14 diagnoses. They've looking at a couple common outcomes. Just look at, can you better underestimate sequences? And for the sake of time, I'm not going to go into a ton of these, but really just thinking about like the order of magnitude. So we're really interested in, if you build these sequences, do we get more informative paths to the outcome? The value themselves are not super important here, but the relative order of magnitude is. So if you know where you came from and you let it skip things that are not relevant to reaching the outcome, we're several orders of magnitude more likely to know how you will reach that, how that kid will progress through a pathway to things like heart failure or hypertension, rather than saying just, will they get it? We published this was great, people were interested in it. We immediately got questions about like, well, we just stick this in deep learning models. And like, cool, like wonderful. And they're like, we just want the sequence to go into this. And what we were able to show from that is that if you know the pathway that a patient is going to take, if you tell the deep learning model that this pathway is useful to know heart failure, it's actually much better performing, not much better, but it performs better than if you just let it figure out the sequence on its own. So knowing the how is actually quite useful. So showing that, so Birch is a sequence prediction model, people use it all the time, it doesn't really matter. It predicts this outcome for this patient if they have heart failure. It does a fine job, who cares? But it matters that if you give it, so EMBS is the pathways that we built. If you know the pathway, if you teach it that this pathway is informative,
it does better than if you just give it a bunch of sequences and you tell it to reach the outcome. And what we're really hoping that this spawns is people being interested in how you got there and not just that you did. So this was great. We published this. It's interesting, I guess. What we're really interested in now is translating this into how you use it clinically and thinking about like, can you identify deviation points along the sequences? So if we know if you're going to reach an outcome, we can actually work backwards. So thinking about like alignment techniques, we can know when you are walking on a sequence, when you deviate towards a bad outcome. And this seems like a great point to study interventions. So like, how do you identify the best point in a patient's trajectory for an intervention? Well, it's where they are deviating or right before they would deviate to a poor outcome. So if we can model the how they get there, we can actually work backwards quite effectively, it looks like potentially, to identify where the deviations happen and then thinking about designing interventions around that. Now to Toby's point, like what happens if they're not being measured? Well, that's just not, that information is just not there. So what we're thinking about is like, if you have yeses and nos, so there was a really great paper that looked at the knapsack problem, where I don't know if you didn't get this diagnosis because you didn't have it or because it wasn't measured. And they did all this work showing that you can actually model that, where you can say, if I tell you that this person had the disease and they didn't have the disease, like, so we didn't measure it, that's our fault. But it doesn't mean that they don't have it. So I don't know. So I'm going to do it twice, once with the disease and once without the disease. I'm going to look at how this impacts their outcome. And they were able to show that you can do some really cool work with all these permutations of what they have and what they don't have, all the different classifications of a person, all the different labels, and how that permutation affects this outcome. And what we're hoping is that we can integrate some of that into these sequences where all these things that are happening or not happening, we can think about them. They were able to show already that you can do it for better diagnostics, where we know what we should test. It was a cost paper, it's an economics paper looking at how do you prioritize what tests to do, because which individual, what don't you know that would be most useful to capture next, which was great. We're really interested for what you know, what you don't know, and how it will impact your probability of reaching the outcome. We already showed that we can build this that tells me how I'm going to reach the outcome. Now we're asking, I don't know if I didn't measure this, and that's totally our fault. But if knowing this isn't going to change my probability of having this outcome, like I'm not going to do it. But if I don't know it or it wasn't done, maybe we can integrate some of this other stuff that people are already thinking about. I think there's some real opportunity to think about missing data as a product of care or as a product of these other things for like, what do we collect to better estimate if it will change your trajectory.
This key decision point or this key deviation point, to me seems tremendously relevant, right? Like, cause
Yeah.
this is relevance, like,
We hope.
and if in fact, if true, right?
Yeah.
It is absolute relevance and not just in, let's say, physical health, but I'm also thinking, like, I don't know if people work on this in mental health, right? Like, where's the deviation point for anxiety? Where's the deviation point for depression? Because these are, obviously there's more uncontrolled variables, so it's probably a more difficult lift, but to me, this is relevance.
Yeah, I would think that, I would hope that it is. I think we're running up into it now, and what we're hoping that we can find some funding for in the future is to think about, this was great for diagnostic sequences. It does not reflect the complexity of care. We were trying to add in like things like labs and procedures. Like we need a more heterogeneous sequence than diagnostics to identify deviation points. Because it's the things that are happening, not just the diagnoses that are happening. So this was great. It's academically really great. We're hoping that we can find some funding to move this from diagnosis to like EMRs.
This is all based off diagnostic codes. Okay. So
Yeah.
like, so I'm the kidney doctor that
Oh.
doesn't like the bone thing.
Yeah.
But I, so I do a lot of EHR research too, but what I would say is that the diagnostic codes for like CKD are like very, very poorly used,
Yeah.
right? And so you're in a subset, but the nice thing about kidney disease is that there's a lot of other objective lab data that you can add to that to become like a much more robust way. So as you're thinking about kind of build stacking, ICD codes on other kind of data points to build these trajectories, like I think those are the types of things.
Yeah, absolutely. Or you could just run it on labs. Like it
Yeah.
just, I guess, I shouldn't say this
I'm
is
good.
diagnostic. This is univariate. It builds a sequence of something, which is great, but it's not enough to identify real deviation points. Like we can identify deviation points, it looks like in this, but like that doesn't matter. It's just when you got diagnosed with this code. We're really looking at like when you were deviating physiologically. So like we're trying to move away from like just because we're worried. So like I do a lot of congenital heart stuff,
Yeah.
and like these kids are only coming in once a year. So like
Yeah.
cool, like you identify this deviation point, but like you had 11 months that something could have happened. Like that's really not going to get us all the way there yet. So like we're trying to use some interstage home monitoring stuff to identify deviation points earlier. So we have some stuff on like how does home monitoring, give you the ability to identify deviation earlier. So we did some anomaly detection work there. And like where patients are starting to go off the rails. So like, can you look at that stuff to get you there? And that seems to be promising.
Keith, I think just a statement like this does, I agree with Gary, this feels really, really relevant and really, really broad. Like you could imagine this in the outpatient clinic setting, like if you're imagining a known pathway from, health to mortality from heart failure, you could think about intervention points of like, sleep apnea and obese folks that like actually probably changes the trajectory that could inform like both testing as well as treatment options in terms of motivating things in the ICU. You can certainly imagine this as well, like in terms of, development of potentially iatrogenic comorbidities that, change and alter, trajectories going forward to kind of motivate, in real time, like, hey, this is really something you should be looking at. It just augments, it doesn't take away any of the clinical decision making. It just creates an point of emphasis in terms of, that partner decision or that clinical decision making that brings together nicely, I think, a lot of data that ends up not being well assimilated for many clinicians.
Yeah, no, I would agree. And I think that, yeah, there was some hope that this would fuse with some of the representation trajectories where we were really interested in like, if we can model the patient's trajectory with more comprehensive profiles, rather than saying that we're going to model the patient's entire EMR, doing some of these embeddings a little bit more specifically. So like ventilation profiles, we have one looking at exercise profiles, and then you can model how that profile changes over time. And like maybe that would be a better way to do it instead of picking and choosing. We're still picking and choosing here. I hate to contradict myself. And we're saying we shouldn't pick and choose in the first, we shouldn't pick and choose here. So if you can build these embeddings and look at how that changes over time, could you use these techniques to identify that deviation? Hopefully.
Is the cutting edge of these methods in healthcare right now, or is this applied for industry?
No, we are laggards to the nth degree. I would say the cutting methods, I mean, yeah, I would, I think it's hard. So full disclosure, one of the groups that built the higher network was my old PhD advisor. So like, I'm obviously biased, but like, came from ecology. Like that's where all the money came from. Like they had people funding Arctic shipping routes for years, looking at like invasive species, and ecologists were funding this. I would say it hasn't been funded at all in healthcare. We got funding from philanthropy to do this work actually, because we had a donor that was interested in trajectories of PPD in kids. So like, so I think I don't think that we are on the forefront of these methods, and not just because the money's not there. I think that we're not on the forefront of these methods because our data is just too poor. I think that our data is in such bad shape that these methods assume that the trajectory is what you're studying, not the probability of the data being real. And I think to your point, like this gets even worse when the data is uncertain. Like this doesn't work, to be honest, yet. I mean, this works if I know how two patients are moving between something, but like if they're not moving between something because they didn't get measured, like I can't learn it. And like I can do my best to skip noise and to deal with uncertainty, or like it took them weeks to get it measured. Like that was kind of one of the drivers for this, is that like some of our kids just like they don't come to their clinic appointments, so it just takes them longer to get it measured in the heart space. So like, do I care about that? No, I really just want to know that A led to B. So I don't care how long it took them. There was a little bit of work after the fact looking at decaying time work, but like it actually found that wasn't useful. That was like, I hoped that like the longer it took, the worse it was doing, but I would say that no, until our data gets better, this is not going to be the cutting edge. Yeah.
So I'm a little bit aware of time, and I also wanted to, I don't know if you had more slides to kind of present, or whether I could kind of ask a more general question.
Yeah.
So obviously it's been a very engaging seminar, and lots of questions and lots of interest. And to me, suggests that there's a lot of interest in the methods that you're using in our group.
Yeah.
And of course, one of my goals is in these seminars is to kind of bring people here who may be potential collaborators. I'm just wondering, like, what do you need from CHEAR? How can we be of service to you? What kind of collaborations are you looking for?
Yeah, I mean, I think this is great. I mean, it seems like people have thoughts. That's the first thing. I mean, no,
That's true.
no, I mean, I think what we're looking for is collaboration. We're looking at thinking about, I mean, I tell people all the time, and I'm sure the two people that have met me here already are tired of me hearing this, but like, I'm really interested in thinking about programmatic work, not project-based work. Like, how do we think about programmatically, like, are there efforts and coordinated projects that in an area that I think we could do a lot of good work. I think the one-off project that dies has been really problematic, where it just doesn't lead to translation. But if there's a group of people working in an area that are interested in this, like if there's interest in measurement, if there's interested in care differences or trajectories, like I think that could be a body of work. So if there's people who are interested in this area or these spaces, I think that'd be great. People that want to write grants together, I guess, in this world that, things are disappearing rapidly. We are trying to be nimble. We had some stuff change recently, so I think, we're trying to be flexible, and I think people that want to do work that impacts patient care, I think would be good. I mean, I think we are really interested in, one of the big reasons for the move to Michigan is, we have a strong collaborative program being in learning health sciences. I think, we did a lot of good work where I came from and we still do it. I think that moving it to clinic is interesting. I think if people are interested in what the next step of this is interesting to me too. So clinician partners are not welcome, but needed. I mean, we have great neonatologists that do work with me. I think, if there's people in other areas that do work that I don't know, I think that would be awesome. Yeah, I think in general, people that want to do collaborative work is what we're looking for. And I do mean like collaborative work. I think we're trying to move away, outsourcing projects, and we're trying not to offload work to students. We're really interested in like, how do you develop students' ability? So I have a strong interest in training, like a huge interest in development of technical trainees in clinical settings. So how do we develop the individuals? How do we teach them that it's the data generating process? How do we bring individuals on rounds? How do we get students embedded in clinics? How do we think about, the life cycle of a project from conception and identifying clinical need to implementation? Like, I think I'm very interested in thinking about collaboration as part of a process, not just we have a project here, like you have some productive time, let's do this. I'm really interested in finding people that want to build work together with me and our students. So yeah, and I think I know we have 1 minute left, so I think I will just skip all this. Don't worry about it. But your question about the temperature is this. So can you generate reference ranges? I guess it's gone. I must have took it out because I knew we wouldn't get here. But yeah, I guess not. So I was gonna say the menu levers thing is something that we're really interested in. So one open area that I'd love to talk more about is, so the menu levers to pull idea that this is something that we haven't really started a ton of work on yet, but I think that as computer scientists or epidemiologists and stuff, like we're so interested in the association between things, but like those things, like the importance of that thing actually fragments when there's a lot of ways to get there. So like, I'm really interested in like thinking about how do you think about when there's a lot of ways to get to the same output or the same way to stabilize a kid, like associating any one factor to the outcome is actually doing a disservice because the people that took the other pathway are actually weakening the mathematical support of that association. But it doesn't mean that that association is not important. So like, I don't know this, and this is an area that like I'm actively interested in exploring. Like when there's a lot of ways to get somewhere, like how do you think about the understanding the pathway to model and process this? Because it's important. It's not that these variables are not important. It's thinking about them more holistically. So yeah, we've got 1 minute. I'm here to stick around if people have questions. I'm going to talk about cardiology, but I guess if I leave with nothing, I want people to take away that like I really want to move away from machine learning as like this idea that it's just going to make things faster or more efficient. Like I think it's a different way of thinking about it. It should help you do something that we're already going to do. It's not making it more efficient. It's not automating. It's not finding cancer in the diagnostic imaging. Like it's great and it does really well, but like that's not really what at least not our group is interested in. Like I think we're really interested in like what do you do with this to make decisions more effective. So I should show this stuff because they helped us do all the work. Yeah. I don't think this is a big slide.